to use our judgment more than ever. And also for the well-being of our patients, not to subject them to all these tests that are dangerous, expensive, and sometimes come with complications. So again, we will always need a good doctor to be very selective about the kind of treatment. And we go back to the surgery performed on heart patients. Sometimes there are studies showing that even on the patient with triple vessel disease, which by the way in the past showed conclusive evidence that surgery prolongs life, now it's being questioned and the treatment offers the same results as the surgery. So who is right, who is wrong? Once, I used to be an advocate for surgery and be very aggressive. I lost one single patient who was stable. I sent him to a surgeon, some complication occurred, and we lost him. And I felt bad from that day. And now I think twice, 10 times before I even send someone for surgery. So this goes to show nobody's right, nobody's wrong, but we have to be very judicial in our choices and use our clinical judgment and act as a doctor rather than rely heavily on all kinds of imaging modalities, which after all, when I get all of these tests on a hardcore paper, we're not treating a piece of paper, we're treating a human being, and that makes a whole difference. You have to see also if the patient can take that kind of surgery or that kind of treatment, and to see, balance it out and make a decision as a doctor for the well-being of the patient, ultimately.
Oh, man.
Let me add to that. First of all, a physical examination is becoming a lost art, period. It's scary. As a specialist that goes to the emergency room, after emergency room patients have seen some patients, specifically in my field, I'll say, well, what does the pelvic exam show? I didn't do a pelvic exam. Why did you do a pelvic exam? Well, because we had a CAT scan, and the CAT scan showed what it was. Well, that's just not true. And I would come in and I'd examine the patient, and she would not have anything close to what the CAT scan found out what they thought it was. Also remember that medical error is a significant portion of everyone's life. We're not perfect. The doctors who read the CAT scans are not perfect. So I want you to understand that just because a machine does something, it means that that's right and the doctor's wrong. We're treating patients, and it's a lost art. And if we don't stop doing that and start teaching our new MDs that come out, or DOs that come out, that for the most part, you have to examine the patient. You have to be there in the room, listen to their stories, understand the symptoms that the machine can't pick up. And it's becoming very much a lost art and something that is drastically going to be lost if we let it happen.
I agree with that, but I have a little different perspective. In my specialty, we don't do a lot of diagnostic exams, but I can tell you that my practice has changed quite a bit in the last 20 years, even in the last 5 or 10 years, and all the different new techniques and technologies have just made us much better as plastic surgeons. So the ability to do injectables, the ability to do Botox, lasers, that's really changed the way people can look after the treatments. 10 years ago, 15 years ago, all we had was surgery, and surgery is great, but these new technologies, I think, have really been very, very beneficial.
Is there anybody else? That was a good question. Come up, Jeff.
Do I really get one of those?
You can pick.
Can I give it to somebody? Can I
Sure.
give it to the rabbi's wife? She's the one who got here.
Okay. Okay. See, I don't want to pick her.
Why not? No, you follow me when it comes up.
Yes.
I'm afraid to see what's in there.
What?
No.
Just hand it to anybody.
Yeah, just hand it.
Sorry, I'll take it.
I have a question to.
Wait, I had hand up before, I'm sorry. Yes.
I'm a practicing dentist, and actually we have a lot of patients that we share with Dr. Amron. But a lot of people suffer from sleeping apnea. However, their appliances are very difficult for patients to wear. And the question is, are there any surgical procedures that you are aware that are good results for the patients that you can recommend?
It's a good question. Sleep apnea is, first and foremost, probably one of the fastest growing diagnoses and accurate diagnosis. And part of the reason is because our diet and our weight increase over the last couple decades is our diet has worsened and our weight has increased. That being said, what I treat obstructive sleep apnea, there's two types. Obstructive sleep apnea, which is usually due to the back of the throat, the base of the tongue, the uvula, the dumbbell down there, the tonsils, and the back of the tongue. And what I do is I restructure that area. So instead of it being flaccid, and when you lay down covering your airway, it's open and taut. That surgical procedure is very popular. It's not for everybody, but it's highly successful. I cannot, what I tell the patients is, I cannot guarantee that it will abolish your sleep apnea, but it will help you for the rest of your life. It will help for the rest of your life. The key is to keep the weight down and to make sure that you don't drink alcohol late at night. Alcohol relaxes smooth muscle, and that's exactly the architecture in the back of the throat. The other kind of sleep apnea is central sleep apnea, which comes obviously from the brain, and that's a neurological problem where you're not initiating breathing from a neurological standpoint. Now obviously that's much more dangerous. It's called Ondine's curse, but luckily that's very, very rare. But for sleep apnea, or if you feel that you have sleep apnea, you should get a sleep study where you sleep overnight, not in my house, but we check your oxygen, your heart rate, your brain waves, just to make sure exactly objectively what's going on at night. Because if you do have bad sleep apnea, it's just like sleeping with someone with a pillow over your face. You have to get through so much inertia just to get the oxygen your body needs. And that leads to right-sided heart failure, weight gain, cognitive impairments, and ultimately early death.
Dr. Rothenberg.
Actually, this is for Dr. Kotzman. Dr. Ben Simon anticipated some of this. Do you really believe that female hormones there's a link between that and breast cancer, or is it the fact that these patients on the hormones are the ones who are getting more of the mammograms and the MRIs, which have become so much more sensitive to the point that they're finding things which are even better left alone? In other words, are we overdiagnosing breast cancer with the upgraded imaging modality?
Let me dissect through your question. Are you concerned that as to the origin of breast cancer and whether it truly is related to estrogen replacement, number one?
Yes.
And are you concerned that maybe the radiation issues surrounding mammograms or other modalities may be also potentially increasing the risk of breast cancer as well?
But I think I suspect we may be overdiagnosing.
Overdiagnosing.
Finding small breast cancers which would never cause any trouble if we left them alone.
Well, that's a really interesting question, and I don't know if you're going to get a prize for it, but it's a good question. Let me say this. I think the controversy over estrogen replacement is just like Rabbi Ezagui said. I think 20 years, just like 20 years ago and 20 years in the future, we will have strong feelings that swing back and forth regarding the real findings regarding what causes breast cancer. But I will answer your question this way. I think that the radiographic issues surrounding increasing your chances of breast cancer is certainly there. I think the more we give radiation, the more chance we have risks of causing cancers. But I will say this, it's my understanding that the newer technologies radiographically have diminished the amount of X-ray exposure, number one. And number two, I believe that there has been a big swing in this country away from self-breast examination because we find that our modalities are now much more able to diagnose breast cancers because of the acuity of those X-ray studies. If you see, before maybe 5-10 years ago, that's all the doctors talked about, self-breast examination. Everyone's got to examine their own breast. Well, the truth be told, they've taken a whole bunch of more money from the private sector as well as the public sector and putting it into better machinery in order to better diagnose breast cancer at a much earlier stage, that by the time you get to feel it with your own fingertips, it's well far along more compared to finding breast cancer much earlier on. And I think it's demonstrated by the fact that not only are we finding them earlier, but our breast cancer mortality has dramatically dropped during the course of the last 2 decades because we are discovering them earlier, and that's our only protection with breast cancer, is discovering them earlier.
But my concern was, pardon me, like prostate cancer, we're finding things which would be better not found, left alone, not treated.
Well, that's a whole different disease process, and we all know that prostate cancer is one of those things that if you do autopsy study on 90-year-old guys, you're going to find 80% of them that have prostate cancer. It's a very indolent course, especially at an older age, but I don't think that breast cancer follows that same route.
Thank you. Do you mind if you don't want it? I have to pick people who are not asking me questions. Yes.
This is just a really easy question. I just want to know if all of these doctors up here take Blue Cross and Blue Shield.
I'm sorry, what was the question?
What was the question?
It's an insurance question. Would you like to say that a little louder?
I want to know if all the doctors participating tonight take Blue Cross and Blue Shield.
Yes.
I don't take any commercial insurances. I only take Medicare. So I don't take Blue Cross Blue Shield.
Pretty sure we don't. 100%.
Do you take Medicare? Rabbi, do you take Blue Cross?
I take it for free. Just come. You don't even bother coming through the door. Just come.
Yes, Mike. Mike.
Dr. Ben Simon, can you reverse plaque and cholesterol buildup with exercise, diet?
Once established, you cannot reverse it. However, you know that the arteries are elastic, and they go from 1 to 5. They dilate. So it's a dynamic process. When they tell you there is a 70% obstruction at rest where the artery is not dilated. But if you provide intravenous nitrates, then there is a dilation of the artery. Or if you exercise, that same artery dilates and 3 times the lumen of the initial caliber. And therefore, from initially being 70%, it becomes 40%. So it's never too late, not to reverse the condition, but to prevent it from getting worse. From taking, I'm a firm believer in statins because they reduce the incidence of cardiovascular death. You work on all the risk factors, high blood pressure, smoking. Take antiplatelet agents, whether aspirin or Plavix, or things of that nature, and you protect yourself. But definitely, there is no reversal per se, but there is prevention of worsening of the plaque formation.
I think we have time for one more question. Yes.
Dr. Shooter, with regard to reconstruction after breast cancer and mastectomies, the DEEP procedure is something that's been coming up and along the way over the last couple of years. Is that something that's going to continue to evolve and become more of a gold standard versus the implants?
Well, I hate to keep saying this, but I don't do breast reconstruction in my practice, but breast reconstruction has changed quite a bit. Also, as I said before, in the last 20 years. And you're correct, using autonomous tissue, microsurgical techniques, using your own tissue versus using an implant does have a very significant appeal. You're replacing your breast with your own tissue. On the other hand, these procedures are not easy procedures. They're long, they're risky, they're difficult procedures. You need to go to a place that does them frequently, mostly in big medical centers, whereas an implant is a very, very simple procedure. A breast reconstruction with a new cohesive gel silicone implant can be an unbelievably good result, an unbelievably good reconstruction, and that's a procedure that could take an hour or less compared to 6 hours or 8 hours and risk of losing the flap or partially losing the flap. So all of those things have to be taken into account. If you have a patient that is a young, healthy woman that is willing to go through that type of risk for potentially an outstanding reconstructive result without ever having to think about an implant, that's one thing. But if you have a woman who's a bit older and has some heart disease and is diabetic and has other risk factors, you have to weigh those risks. So I think a deep flap and other types of elegant breast reconstructive procedures are really great, they've come a long way, but sometimes the easiest procedure is pretty good too.
Dr. Petzl would like to.
I don't want to, that ends that question. I just have to, I would like to answer one of the questions that Label has brought up. And that is the future of healthcare, or at least the discussion of healthcare in our society right now. And so I have a very brief statement to make about that, but so I won't belabor it. The big impasse in this country, in healthcare right now, is moving from a place where we pay doctors and healthcare providers to give you services based on what they do. In order to make their living, they order tests and they do procedures and they take care of patients all appropriately. However, there is a big change in healthcare where we have to find the bridge that goes to the other side of healthcare, which is the only affordable healthcare that this country has. And that is, instead of paying doctors, etc., for what they do, is to instead take care of people to keep them healthy and to take on large patient populations and learn how to keep them healthier and to be paid properly for keeping them healthy. So from the perspective of that, it's very difficult to change over from one system to the other because we make our living by doing things. We need to learn and we need to be incentivized to take care of healthy populations or sick populations or make them healthy or keep them healthy and be appropriately incentivized to do so. And that's the big impasse, and that's what everyone's struggling with, and I don't think anybody's got the right answer. But that's the direction that healthcare has to go, because we simply cannot afford to pay for our healthcare in this country.
I hope some of our doctors can stay around, maybe me both, but I thank everyone for attending. I know I learned a lot, and anybody interested, any of you ladies who are not on our mailing list, please see me or Connie and give us your email and know of future meetings. And I would like to thank our whole panel of doctors, Dr. Benson,
Just want to say one thank you. They never get to thank you, but thank you to Anita and Meryl Cohen for putting it together. Yeah.
We want these chairs back in there again. We want them back in there. We gotta talk to Connie. She's like,
I'll handle it. We'll work a robot. Very good, very good. Excellent. It wasn't very good. It's a video. It wasn't. Yeah, I took a video.
Of what?
The whole thing.
Oh, you did?
Yeah.
The